So we're going to wrap up the axial skeleton talking about really an integration of the axial skeleton to the appendicular skeleton, and we're going to look at posture and gait. Now we've talked about posture already a little bit when we were looking at the cervical spine and the TMJ and the thoracolumbar spine, but we really haven't talked about gait. So they're really one and the same. When we look at our childhood development, we're looking to get from a quadruped position to standing as quickly as possible. And then from standing, we're trying to take our first steps as quickly as possible. And this drives our neurological development, it drives our functioning, and in fact, in physical therapy, if you're not hitting certain milestones for standing or walking, this can lead to significant developmental delays. So when we look at posture, this is what's considered static balance. We're looking for this straight line, and not necessarily straight like the spine is straight, but a load line that's going through certain markers of the body, starting from the head, shoulders, the hip, the knees, and the ankle. And this is really representation of the line of gravity through the center of mass, and making sure that we're balanced both anterior, posteriorly, medial, and laterally. And just to review, we've talked about center of mass, but if we look at the footprint that we make on the ground, so this is you looking inferiorly up at someone, there's a base of support that's created by the perimeter, the outline of our contacts with the surface of the earth, and within that is our center of mass. And if this center of mass stays in this position, we're balanced. And in fact, if it stays in any element within these boundaries, we stay in balance. The moment it comes outside of this boundary, one of two things is going to happen. You're either going to fall, or you need to adjust your center of mass or the base of support so to capture this again within that. So when you pick up your one foot, what ends up happening is your base of support is reduced down, and you have to shift your weight so that your center of mass goes from here, which was between your legs, within the base of support that's now created within your foot. And every time you take a step, your center of mass is shifting, and you're shifting your weight back and forth every step, one foot after the next, one step after the next, until you come to a 2-foot stance again, and you are stable and balanced. Now what that crosshairs was representing was this plumb line that's going through these biological or anatomical markers. And we look at this both from the anterior posterior perspective and a lateral perspective. And you can see the landmarks here. You look at the external meatus, or the ear, right at the AC joint, through the midpoint of the trunk, but then to the greater trochanter. We talked about the pelvis being neutral here, where the ASIS and the pubic symphysis are in the same plane. Slightly anterior to the knee and right anterior to the medial malleoli, so that you are right within that middle base of support. Now the way this is assessed in a lot of aspects is a visual component, and you'll do some photo assessment, or they have these grid-like charts that you can put against the wall, and you can look and you can see, like through midline, like right now her face, she's a little shifted to her right, and I start to look to see, is that coming from the shoulders, from the spine? We can look from here and see, like here, her ear is a little forward, so she's got a little bit of forward head posture. And you look at this from each plane, not so much the transverse plane, but definitely from an anterior posterior perspective and a lateral perspective. And this is the ideal posture that you're looking for. This through the earlobe, through the acromion process, right through the lumbar bodies, right at the midpoint of the spine, the greater trochanter, and just anterior to the knee, or posterior to the patella, and anterior to the lateral malleoli. So this is what appropriate posture is. And why that is important to us is that when we look at your ability to stand upright, your muscles are not contracting the entire time to hold you up. Your body is trying to turn muscles off as much as it can. And what's happening is, as you're standing here, you have a little bit of anterior sway or posterior sway, and you got a little bit back and forth, a little tug of war. So it's not that the plantar flexors are on or the dorsiflexors are on. If you start to go into a little bit of anterior sway, your plantar flexors are going to turn on, and you're going to create a little bit of, it's going to pull the knee back, so it's going to create an extension moment at the knee, it's going to create an extension moment at the hip, and that's how you're going to stabilize. And it's just enough to get you back into position again, and then it turns off. And then you either have one or two things. You either stay steady there for a while, or you start to sway back a little bit, and now your dorsiflexors come in and pull you forward. And you come forward too much, now your plantar flexors come on and pull you back. And it's really just the soleus and the anterior tibialis and the extensor digitorum that are doing that. And that's how you're keeping upright. Now you're keeping a little bit of locked extension, but when you're standing and your knee's locked, the muscles are off. It's the skeleton that's holding that, and your little bitty stabilizers to keep that knee extension terminal That's it. This is why patients that are post-op knee surgery and they can't reach that terminal or full extension, they have problems standing for long periods of time because they're fatigued because the muscles are on the entire time. Now the muscles need to relax. This allows circulation to come through, and this is what for energy conservation. So when you look at people that are chronically tight or chronically toned or muscle adhesions or knots, you start to get altered neuromuscular control, and it starts from posture. So now posture is complex because, as we've talked about, one movement at one joint is going to affect movement up the chain. So as we go through an anterior posterior pelvic tilt, we're going to change things at the spine and at the head and through the rest of the spine and possibly down through the lower body. You can't really change one thing without affecting the other. And this is all looking from a lateral view, but we can also do this from a posterior anterior view and can see this lateral shifts that are occurring. Anything that's deviating from normal asymmetries or things that are outside our plumb line. The complexity of this is that the body is interrelated. And so when we look at this shoulder being down or this hip being hiked or this knee being, this valgus position that's happening in the knee, this might be coming from the foot, it could be coming from here, it could be a combination of all of the above. And so you have this kinetic chain aspect where the arch affects the heel, which affects the ankle, and so it starts to become an investigation. So just because you see something happening, a distortion at one part of the body, doesn't mean that's where the problem's at. It could be, but it could also have other downstream effects. And dysfunction at one joint isn't always in the same instance. So you could have started with like a flat foot that started to create this problem here, and now you start to present with this hip drop. This has been going on for months. This is a new problem. This stays on long enough, this shoulder starts to drop down, and now you have 3 different sets of dysfunction that are related. This has been going on for longer. This is more in the acute phase, this is in the chronic adaptive phase, and this is an inflammatory phase. So you're going to be dealing with multiple temporal and multiple time aspects along with multiple mechanical aspects as well. As you start the process of trying to identify where things are at, you're going to probably fail miserably. You can identify postural distortions, say, hey, this is what's going on, it's a red flag. But to try to determine that that's what the problem is, that's what's going to take a little bit of investigation. And as you start to change things start to shift and shift back, and that might have been a compensation for something else. So it starts to become a fun game of cat and mouse as you start to chase the dysfunction through the body, kinetically, biomechanically, and tissue. I have this slide here just to represent that you can't stick to one plane either. So here you're looking at an anterior, so you're looking at an anterior view, so you're looking at lateral plane distortions, but you can see that transverse plane aspects can happen and affect sagittal plane motions. So you can get this triplanar type effect that occurs from these posture assessments. Also keep in mind that posture is very complex, and so you can have distortion in body positions that have nothing to do with musculoskeletal stuff alone. Like you have your whole sensory, motor, vestibular, and ocular components that affect the postural position, where your head goes, your body goes, where your body goes, and so forth. And so you can be dealing with motor control type issues, sensory aspects, and of course musculoskeletal components. So just keep in mind that posture is complex. It's more than just, hey, it's, oh, you see this, I'm going to fix that. It's a red flag, it's a starting point, but as we've talked about throughout the entire thoracolumbar and cervical and head and neck and TMJ, there's things that contribute, and these are not just a one-time incident. These are adaptive processes from lifestyle aspects, from sitting, from proper shoe wear, and so forth. If posture is complex, gait is even more complex. So when we look at gait, we have to divide and conquer, if you will, because when we look here, we can see that the normal human movement is right lower extremity with the contralateral upper extremity doing one thing, and then the ipsilateral or the contralateral lower extremity is working with the contralateral upper extremity. So your right leg and left arm are working in concert doing one thing, and your left leg and right arm are doing the exact opposite. And there's a rhythmic of arm swing and leg swing which is happening through the shoulder girdle and the pelvic girdle, and so gait is really complex. And it's difficult even if we divide and conquer, but usually when you look at gait, you start with the lower extremity, and that's what we'll start with this aspect. And we're going to just scratch the surface on this. We're not going to get deep. We're just going to introduce basic concepts, basic terms, and as you progress in your careers, you will start to appreciate the gait cycle and understand the power of understanding how to map it out and what to do with it from a clinician perspective. But basically we start down and we just look very much at what's happening when the foot's hitting the ground. And so we have an aspect of alternating left to right foot, and you have a left step and right step, and one step of each leg, left leg, right leg, makes one stride length, and one whole gait cycle is one left foot hitting the ground, starting over again into one left foot. And so this is looking at the gait cycle here, where you have left foot strike, so right toes on the ground, and one whole gait cycle is right before that toe comes off again. So you have your stance phase, swing phase, and so you have these different phases that you can use to kind of categorize. This is the image from your book, and it talks about this aspect of the gait cycle. And the gait cycle is composed of two phases. You have your stance phase and you have your swing phase. Your stance phase is when you are when you're making contact with the ground, and there's only 2 points where you actually have 2 feet on the ground. So we looked at that base of support, where your base of support is stable, is here, and for the majority of gait, you're in single leg support. So you have a single leg stance phase when one foot's off the ground, and this is happening with swing phase. It's happening on the other side at the same time. So you walking is basically single leg stance for the majority of it. And we look at swing versus stance phase. It's about 60-40. In most people, a little bit biased in that aspect. This is just normal free speed walking, just walk without thinking about your speed. And what you'll notice here is that when people try to walk faster, you start to get a repartitioning of how much time that they're spending in each of the phases. They actually start to increase their swing phase, and they decrease the amount of time their foot's on the ground. Now, we're not going to analyze running, but if you were to go from a walk to a fast walk to a run to a sprint, you would see that the stance time is shortened more and more. And if we actually look at that from the gait cycle, you can see that the reason why the time is shortened is that there's a airborne component. So the big difference between walking and running, it doesn't matter if you're jogging or sprinting as fast as you can, is that there's a float or an airborne component. There's a point of time where you're not on the ground. And when you look at sprinting versus running, you'll see that the time on the ground is shorter. And when you look at the very fastest sprinters, their time on the ground is short and short. The less time on the ground, the better. You're just hitting the ground to propel yourself, and then boom, you're airborne again. So that's then gets in the whole conversation of like barefoot running and foot strike, and how our foot mechanics of running should be different than walking because of are you heel striking or forefoot striking? But that's, again, another conversation, a very interesting conversation, but outside the scope of this particular lecture. But the point here is that as you increase your speed, you decrease your time that your foot's on the ground, and you increase the time that you are swinging or transitioning from leg to leg. So when we look at the gait analysis, we're looking at these different phases, and there's different terminologies. And the traditional terminology is, you can see here, heel strike, foot flat, mid stance. But the Rancho Los Amigos scale, which is used big in stroke and assessments for spinal cord injuries and consciousness, and so there's a lot that's going on with like rehab. They have their own terminology that became a little bit more appropriate, and so I share both, but your textbook introduced both, and some people have adopted this terminology and some have this, and there's some really great textbooks out there that are classics that only use a traditional terminology. So it's good to understand both depending upon the way you're studying. But it doesn't change, right? You still have your contact ground, your single leg stance versus double limb support. It's just the terminology that's used for that. When you look at analysis now, there's a lot of things to look at. When you look at each stride, particularly each stance or step that you're taking, you have these different phases: the weight acceptance, so the actual contact, the single leg support, and then the swing. And you have these sub phases that occur that can get your attention when you look at biomechanical analysis or when you're looking at what's going on here. And so there's a lot of the ways you can describe it. You can look at like spatial description, like stride length, step length, or foot angle, these type of things here. And then you can have other like timed aspects, like your cadence or your step time, and then your walking speeds. And so those are quantitative numbers that you can actually get and assess and measure. Where you'll be doing most of your assessment is more in the qualitative aspect. So looking at, are they limping when they're walking? Are they not getting toe clearance because they're not hitting the ground? Is their foot hitting the ground flat versus right on the heel? Are they taking like a wide step when they're walking? Or are they scissoring over, their steps crossing over each other? You'll get a lot into the quality. In fact, when you do any type of documentation, they're going to ask you not just how far they went and how fast they walked, but what was the gait quality? Was there a step 2 pattern where instead of like taking one left step and a right step past that, they were bringing left foot forward and right foot up to that. the analysis of this can get crazy, right? So when you look at the aspect of the single leg stance and what's happening, we've talked a lot about this in our hip and spine aspect, that when you pick this leg up for swing and you're in stance here, so this right leg is going to be advancing forward, there's a whole musculoskeletal response that's occurring to make sure that your leg's not dropping. In fact, this has to actually come up a little bit so you don't trip over your own toes. If you were to watch someone center of mass walk when they're walking, you see this rise and lower with walking. This gets more intense or more extreme with jogging, so you'll have more of an up, down in this capacity here. But if you look at the joint by joint, plane by plane, there's quite a bit of things that should be happening. So we look at the pelvis, we look at the hip, we can look down at the knee, we can look at the ankle. You're going to get the most amount of range of motion out of the sagittal plane. None of this that I'm showing right now is necessary. It's just to show how deep this can actually go. So these next few slides are just kind of looking at the level of analysis that goes in there. Again, this is from the frontal plane and then also from the transverse plane. You can see the amount of internal versus external rotation at the hip, and that's happening down at the knee and down within the foot. The reason why I have this slide here is to appreciate that there's quite a bit of motion that's happening in the transverse plane, and the transverse plane is the most limited amount of range of motion that we have. And if you remember from the trunk and spine aspect, the spine itself didn't have as much rotation. Most of it came from the cervical spine, and as we'll talk about, the cervical spine isn't really involved in generating force for gait. It's more involved in keeping control, like the steering wheel, if you will. And when we look at what's happening in the body, as I said, that you have the lower extremity tied with the opposite upper extremity, and they're doing one thing, and then you have the contralateral arm or limb, the opposite, doing just the exact opposite. So you're getting this loading through this kinetic chain. You can see here through the left leg, through the pelvic girdle, through the spine, through the shoulder girdle, and on through the arm, and it's working both directions. And you also have a contralateral. So what's happening is you have one side of the body collapsing with gravity, going through what we call pronation, and you have another side of the body that is going through supination. So this is your eccentric loading of the connective tissues and muscles for each step that you're taking, and then this is your concentric, your acceleration to generate force. And as you can see, they intermix here at the spine or the core, right? And the core, I like to call the outer unit, or not me, but that's what I refer to because that's what most functional and when you look at more advanced type movements are looking at, is looking at these load lines that are crossing through that pelvic girdle and transferring force from upper extremity down to lower extremity. And it's really about this transfer of energy between pronation through the kinetic chain at one side and supination through the other. And when we look at what's happening when we do that, and the reason why I brought up the transverse plane is that you don't really have a lot of available motion in the transverse plane through the lower extremity. That all happens up here through the trunk and spine and then transfers back and forth from the arm and the leg are really just extensions of that. You could amputate both your legs, and in fact, we're going to show a video of someone walking without legs. You don't need your legs to walk. What you need is a pelvic girdle and a shoulder girdle and a spine to generate those forces. And so when we look here at the pelvic girdle and shoulder girdle, when you get rotation in one direction, so this is the pelvis turning to the right during gait because one leg's going forward and one leg's coming back. So this leg, left leg's coming forward, this one's going back. And in the shoulder, you're getting the opposite. You're getting left rotation. And this counter rotation of shoulder girdle to pelvic girdle is driven by the spine musculature, and it's enhanced like a slingshot from the one leg that's hitting the ground, that's decelerating and storing energy through the connective tissue, and the other one that's trying to take advantage of that and use that for propulsion for its step. So it's like a spring that's winding back and forth, and you have counter rotation of the thorax to the opposite motion of the pelvis, and you're getting this rotation and bending, frontal plane and transverse plane through the spine. Now this is subtle. It's not happening. It's not like these big movements, but it's generating the forces for propulsion so that you can move forward. And so basically what's happening is you get this counter rotation of the shoulders, you're getting this rotation of the lumbar spine, and you do have rotation of the head, but it's really just to decouple or separate the head so that you can maintain your gaze and stay focused. Like he's looking forward the entire time as his shoulders are rotating back and forth and his pelvis is counter rotating in the opposite direction. What's happening is you're getting this down and back movement from this up and forward movement, and this is generating the forces that are needed. It's like a machine where you're getting these lateral movements to generate extension, rotation, to transfer forces. The lower extremity, the leg, does not have the torque production to be able to do that. The spine does. And so this whole focus of the lower extremities as the driving force for gait is actually misappropriated. It's really happening here in the spine in this counter movement. When you look at all human movement, when you look at all sports performance, throwing a punch and kicking and jumping, it's the counter movements of the shoulder girdle and the pelvic girdle that are driving that. The legs are nothing more than just the extension, and not saying the legs aren't important, but they're absorbing the stress and they're transferring it out. But as Bruce Lee said, you don't punch with your hand, you punch with your legs, right? And he's talking about this transfer of force through that. That's his famous 1-inch punch. So this video here, we're going to just analyze a little bit. I'll provide the link for it. Again, all of this stuff is just for your expansion. If you want to, this whole unit of gait is just meant to get basic terminology covered so that it's familiar with you, but you'll be using a lot of it in the qualitative assessment. But it's very fascinating when you look to see how this is happening. And this is a video from Serge Gradovetsky, who is the researcher behind this, and his research has been around from the 1980s. And you can see here a patient of a subject here that was born without legs and arms, and he has ischial tuberosity. He's walking on his ischial tuberosity. And so as you see here, as he goes forward, he is getting normal hip sway, gait mechanics, that counter rotation of the shoulder girdle to pelvic girdle. And he could have both arms amputated as well, even though the lower arms are. All you really need is that shoulder girdle aspect. So it's just a continuation of the lat as he's going back into extension. And as if you covered up the bottom there and you didn't see that this guy didn't have any legs, you wouldn't be able to tell based on how he's walking. So it's very fascinating in this whole perspective of looking at how the body functions and how the engine of the body is really coming from the spine. And it's the spine coupled between the shoulder girdle and the pelvic girdle. So that's gait, right? The gait, that's looking at the spinal engine theory. There's the whole pedestrian theory, and these are the two competing aspects, and most people look at it from a lower extremity only, but you can't deny the upper extremity aspect. And the reason why it's not looked upon that much is just makes it more complex than it needs to be, and people only need a superficial understanding of gait to really get by.